Let me get some slides loaded up here.
There's one here.
Perfect. Oh, awesome. Okay. So thanks for the opportunity. I was just saying that I think any chance we can get to come out and talk to you guys and people that work with these patients is huge for us. It's we're certainly still in our freshman stage of providing this therapy, so this is great. I'm Mark Taylor. Jessica Hamilton is also one of our point people. She's our ECLS educator. Before I get started, I should say that extracorporeal life support, or ECLS, and ECMO, extracorporeal membrane oxygenation, exactly the same thing. I use the terms interchangeably. I'm going to bounce back and forth between the two, so that's probably the first point of clarification that I should go through. This is what I wanted to talk about, just a little bit about how we came to have this program at Harborview and the patients that we're going to use it on, what ECMO is capable of. Right? See, I already did it. Our current indications, and then some of the things that you guys are doing with these patients, and some of the challenges and barriers that we throw up in your faces as you're trying to do your jobs. So we brought this program here because the typical patient population that we have, these are the patients that we see all the time: severe bacterial or viral pneumonias, traumatic ARDS, smoke inhalation, pulmonary injuries. We're also seeing patients with hypothermic arrest, with massive PE. All of these therapies ECMO can provide some treatment options for, where previously we didn't have any options. So this has been actually a very exciting opportunity for us. We typically see, just from pulmonary failure alone, 25 to 30 patients a year that have such severe injury or illness that we're not able to ventilate them. And unfortunately, previous to this time, we haven't had any options. We've always been very proud of our capabilities when it comes to vent management and pulmonary support. But still, with that, depending on how you define ARDS, it can have up to a 75% mortality. We really had nowhere else to go. And as time has gone on, there's been this growing body of evidence that ECMO can provide some treatment options for these patients where previously there were no others. This is really talking about two studies. One that involved the recent, it's not even going to be 10 years ago, right? The H1N1 epidemic that occurred, where they looked back retrospectively at patients who were treated with ECMO versus those who were treated with conventional ventilation, and they actually found 76% for survival for those patients treated with ECMO versus 45 in case match controls that were treated with conventional ventilation. Pretty significant results, very interesting. People started taking a look at that, moving into, hey, maybe this is a treatment option. The study here is our only really randomized control trial that we have to date. There's one that's in Europe right now that we're hoping gets going. I think they're talking about enrolling cases soon. And it involved comparing conventional ventilator management to transfer to an ECMO center. It actually provided, there's a little bit weak there because not all the patients who were transferred to an ECMO center were actually put on ECMO, and the conventional treatment arm didn't have standardized therapies. They were treated in multiple centers around the UK, but with those limitations, they did see 6-month survival, 63% on ECMO versus 47% with the conventional treatment arm. They also did a whole cost-adjusted life year analysis and were able to show benefit economically to this, which is also significant because ECMO is not a cheap therapy. It's very labor intensive. So that was interesting at all. All of that together, this was occurring about 2009 to 2011. Centers started building more and more ECMO programs. People started hearing about it. The community started hearing about it, and this was just prior to us. This was 2015. There was a couple of patients that we were called about who ended up in the water in Dungeness Bay, near Squim. They were taken to facilities over there on the peninsula, in and out of arrest, very hypothermic, and they thought these patients needed to be treated with ECMO. They called a bunch of facilities. We were one of them. We didn't have an ECMO program. They actually ended up sending these patients to Bellingham. They didn't do well. This was at a time when we were thinking we needed to be able to provide this service not only for our patients but as an option for the community. And this was sort of the one more reason why we needed to offer this. So there's really two modes of ECMO. They both use exactly the same circuit and exactly the same materials, but they're plumbed in different ways. We've been talking a lot about plumbing. I was listening to the VAD lecture and I was like, oh my God, that's so confusing. And then I realized I'm about to talk about this. So okay, so you can't be that bad. So it may be a little bit tough to see. If I start with the VA mode, the veno-arterial mode, which is on the far side here, we're actually going to pull blood out of a femoral artery. We're going to run it through a pump, through an oxygenator, which you can't really see here. I didn't bring a lot of slides to diagram this out, but the pump and the oxygenator are all put right in this diamond shape behind this red diamond here. We're going to run it through that pump, run it through an oxygenator. The oxygenator also has a heating element in it, so we're able to control the patient temperature completely. And then we're going to return it. I'm sorry, did I say we're pulling it out of I should say we're pulling it out of a vein. We're through the oxygenator, and we're going to return it into the artery in the veno-arterial mode. So from the venous into the arterial circulation, the arterial cannula is threaded up really into the just after the bifurcation of the aorta. So the entire this theoretically is running retrograde, right? We're pumping back up the aorta in the opposite direction to supply oxygenated blood to the heart, your brain, your upper extremities, and all the way down through your mesentery and lower extremities. So that's the veno-arterial mode. That mode can provide total, it's very analogous to a bypass cardiac bypass machine, provide total cardiopulmonary support for a patient. And I'll talk about the indications in a minute. The veno-venous mode, which is much more common at Harborview because of the patient population we see, where we're taking blood out of a large vein. Typically we take it out of we're threading it up from the femoral vein up into the IVC. Same oxygenator, same system here, same pump, and then we're going to return it back into an internal jugular vein, into squirting it sort of right at the right atrium. Okay, so that circuit's running completely in parallel. It's taking blood out of the patient, oxygenating it, getting rid of the CO2, squirting it back into the patient's own circulation, and letting their body, their native flow, circulate that oxygenated blood around. It's sort of like providing liquid oxygen. It's essentially, think of it as like a drug that we just inject into the patient. In this circumstance, in the veno-venous mode, they really don't need any pulmonary function at all. So those patients who have horrible pulmonary function, for whatever reason, we can turn the ventilator off if we wanted to. They don't need it. We're going to do all of that work with the pump itself. Okay? So the indications of these, talked about this a little bit. Veno-arterial is going to give us that full cardiopulmonary support. So those patients in cardiac failure, the patients who are potentially going to go on to develop to need a VAD that you just heard about, they may start out on with ECMO support. It gets used a lot post-cardiotomy. So those patients who go to, they're on bypass for their cardiac surgery, doing whatever they need to do. They may be slow weans off the bypass pump. They wean them onto ECMO, and then on ECMO they can slowly wean them over the next day, whereas that doesn't tie up an operating room. It's a much less difficult wean for the patient to get through. So if they're a little tenuous, it might be an easier way to do it. It's a very popular use for ECMO in its current state right now. There's this thing called full arrest support, or ECPR, that where a patient may be in full arrest and we crash them onto ECMO to provide complete support until we can figure out why they were arrested in the first place. Children's has a program for their ECMO team that uses this right now. Harborview may delve into this for some of our VF arrest patients in the near future, but we haven't done that yet. Certainly massive PE, hypothermic cardiac arrest, those are patients we've already seen at Harborview and taken care of. Veno-venous mode, as I talked about, this is really your pulmonary support for whatever indication. Severe ARDS, pulmonary infection, smoke inhalation, bronchopleural fistulas or traumatic injury to the lung, where we have difficulty ventilating them for whatever reason. This may be an option for us. Again, a lot of these patients previously, we didn't have any options. We didn't offer anything, and a lot of them died. So one of the things that I do need to mention is that the treatment strategy for all ECLS, all ECMO, is that it gives us some time. It lets us figure out what the cause is, lets the patient heal. It provides that bridge to something. The patient may not have survived their insult without ECMO support, but ECMO doesn't treat anything. So we need to have some treatment options in the future. For those patients who have irreversible causes, some kind of severe malignancy, end-stage cardiac failure, ECMO is not going to do it for you. We need to have a place to go. You heard about it. I think she talked about a destination. Ultimately, that's what we need to be careful about also. This is our program right now. We went live April 1st. I would think, what was I thinking about? Why did we start this on April 1st? I was just talking to somebody in another group recently. I was like, that was ridiculous. Friday the 13th might have been a better day to start. I don't know. Our first successful cannulation was actually in May, and then we didn't do much for a couple of months until August of that year. And we've been actually pretty steady. We've had a patient on for most of the time since then. I anticipate the program will grow significantly as people get more and more comfortable with this. We've done 24 patients, 25 different runs since then, so it's still very much a building program. We're very much learning as we go with it. This is the breakdown of our indications. Again, the vast majority of our indications at Harborview are going to be for these pulmonary failure patients, and that's really what we're seeing. We have done PE, hypothermia, we've done overdose, we've done cardiac failure of a couple different types. So I think this will expand. And then our breakdown of the modes that we've seen, it's really about 4-to-1 really, 19 and 5, I guess, for the veno-venous versus veno-arterial modes. The staffing of this, the people that you would work with at the bedside are typically going to be your ICU nurse that you are currently working with, but also we add an ECMO operator. And this is either a respiratory therapist or a critical care nurse that we've put through some additional training for the physiology around ECMO, the pump itself, the alarms, the things that they need to watch out for, emergency procedures. It's about a 40-hour course that we put people through. It's based on a national course offering that we have a curriculum for. And I think overall it's worked out very well. I think people find themselves very prepared. So they're going to have essentially 2 caregivers, and both of those caregivers are going to be working together to make sure the patient has everything that they need. 3 caregivers as you guys get there to work with some of these patients. So I think having that collegial relationship has been key. It's a little better picture here of the pump itself. The pump actually fits into this little metal bracket. This is that diamond-shaped thing that you were seeing. This would be the venous, the inflow, the line into the pump, running here in the bottom around the back side. Going to go into the pump, into the oxygenator, and then out of here is a line coming out that's going to provide oxygenated blood. The most common complications for patients on this are bleeding. Most patients are anticoagulated while they're on this. We haven't seen a huge problem with that. I would say the most problem we've had is maybe some oozing here and there, but that can be significant. People can have nasal, like epistaxis that just goes on forever. We've seen that, but it hasn't been horribly challenging for us. Embolic events certainly can be an issue. You heard that with the VAD as well. Air entrainment is something that you guys can help us with. We have to be very careful about air getting infused into the line. It's a centrifugal pump, so it will essentially airlock, and we have to be really cautious about that. These patients are dependent on this pump, so if we entrain air, the machine will shut itself down, but if you entrain too much air, getting that air out, 3 to 5 minutes, which you can imagine, depending on how dependent the patient is, they're in full arrest at that point for 3 to 5 minutes. So we really want to avoid that, and I'll talk about that in a minute. This is just really saying that the patients that we treat with ECLS have severe multisystem failure very frequently, and so as a result, a lot of them are also going to have renal failure, which enter you guys to the rescue with your capes. We hope to, most of the time, be able to provide separate access for these patients to be able to run, most commonly CRT. Could be dialysis, hemodialysis, but most commonly CRT. However, as you can imagine, these patients are pretty sick. They have multiple drips, very few access sites, so running it through the circuit is an option. But it does have some challenges, and I wanted to talk about that a little bit. I wasn't sure how well this slide was going to show up, because this does provide some mapping, I guess, of where the CRT machine can be plumbed to. We've tried a couple of different options with it. So when you're pulling blood out of the patient, it's running at a minimum of about 3 liters per minute. The max is about 6.5 liters per minute. The negative side of the system, the venous side, out of the large vein. So in this picture, out of this large vein into the pump. That pressure can be, I would say, between a low of about -80 and a high of maybe getting close to -200. Pretty significantly negative. The risk there of air entrainment is huge, and so this shows an option where we can plumb the circuit into a couple of different places using the negative side of the circuit. It's possible to do that, but it's extremely high risk, and the risk of air entrainment becomes very significant. We've tried it a couple of times, and we have entrained air both times. The U actually, at their program, uses the negative side of the circuit to run their dialysis on, and they entrain air not an insignificant amount of times. They've done it more than we have, but I am really leery about this as an option, and so I've been really resistant to allowing that to happen. It's really desirable because the other option, which I'll talk about in a minute, is a significantly positive pressure area, which runs into a little bit of a different problem. There are some other exotic systems that we may be able to plumb into in the future, we may think about, but right now that's not something that we're doing. That actually causes some risk of clot formation. So what we're doing now is this. The oxygenator, the picture of it, the oxygenator itself has a couple of pigtails off the top of it. They're very small looking, and the first thing you guys are going to say is these are very small looking. There's no way we're going to flow through those. They flow up to 200 mils per minute through them. We've tested it. The problem isn't the flow, it's actually the pressure that's in the system. And the pressure in this oxygenator can range from about positive 100 millimeters of mercury to up to positive 300 millimeters of mercury. And it's patient dependent and condition dependent and how fast we need to flow the patient on ECMO to support their needs. So that becomes a significant conversation as far as can we or can't we use this method for CRRT, because your machines, my understanding, certainly correct me, is your machines sort of get a little finicky around 300 millimeters of mercury as far as the high pressure. So I think in the acute phase, what we're finding is that this is not really great. At that point, we're flowing pretty quickly, and those pressures are pretty high. In the chronic phase, more typically that pressure ends up closer to 100, 120 millimeters of mercury, and it leaves us a little bit of option for you guys to be able to take your fluid off and return, and still have effective dialysis occurring. So that's the conversation that I'm hoping that we have back and forth between everybody to talk about, whether or not this is going to be a good option for putting CRT through the circuit. Oh, you got no. I got a no. I got one no already.
There was an incident that we have to do a CRT with one of the patients, and our venous of the return on the CRT was really, really high. So our pump speed on the CRT was like only about 60.
Yeah.
It's what we were thinking. It's the what do you call it? The connection. That's what you're.
Yeah, that's what I was talking about. The pigtails.
The pigtails.
And
I think that was the problem.
It's not.
It's not that.
I can guarantee you it's not.
So what was the problem?
It's the pressure that I was talking about. The pigtails themselves, if they're in the absence of pressure, will flow 200 millimeters per minute without any problem.
Because you're pushing against
But you're
that
pushing. But
pressure.
the other side of
Yeah.
that, so no matter how large that pigtail was, the other side of that, and I know that case, the other side of that is, at that point, was about 260 millimeters of mercury. So no matter how large the pigtail was, you were going to be pushing against 260 millimeters of mercury, and there's no way that that would be okay. That's not enough room for you to flow to keep the overall pressure less than about 300, so you had to have your flows very low, because
Yeah.
we couldn't slow our flows down. As he got better, we never tried that again. As that particular patient got better, we actually were on much slower flows, and we could have put it back in the circuit, and nobody particularly wanted to, but at that point our pressure was around 160, and it would have worked fine.
Yeah.
And so that's the thing that we have to, that's where we're going to be constantly having that discussion. You had a question?
I think the patient had a different wasn't connected to the ECMO after a few days.
Correct.
You had so it was much better.
Well, it did, correct. Although over time, did we need that separate access? Because that patient was on for almost 3 months, and he's actually still on. He's over at Children's. But over time, did we need that separate access? Could we put it back in the circuit and gotten rid of an access point? I think we could have, but we didn't.
Would have been worth a try.
Yeah, and I think at that point we had much less pressure as time went on. We were able to slow his flows down because he got less dependent on the ECMO itself, and that's very common. Those first couple of days, our flows are very high and those pressures are very high, and it's probably not going to work right off the bat. But that's the discussion that we have to have. Other questions around that? It's going to be a little bit of a challenge for us all to figure out how best to do this. If we get into a situation where there are no other options, the secondary, trying to find a separate access has got to be something that we're going to have to work on. I really think plumbing it into the venous side, where it's significantly negative. So where we're pulling here, the ECMO access is very negative. It's just dangerous, and I'm not real comfortable with setting people up for that. I think it's going to put people really at risk.
So both of our machines are all connected to the outflow of the ECMO? Both.
Yeah, you're actually here. This is the pump itself, this back part. So you're actually on the side of the pump that's pushing back into the patient, and it's positive there. It's just, depending on how fast the flows are, it may not be as positive as, if we're flowing at around 3 liters, 3.5 liters, it's probably going to work fine. If we
Yeah.
have to flow at 6 liters or something, it's probably not.
It's okay to have a recirculation of oxygenated blood to our machine.
Yes.
Yes.
Yeah.
I think when we were flowing about 2 liters, there was no problem.
Yeah.
With with our CRRT, but when they have to, I think the patient saturation was going down. They have to
go
increase
up.
the flow to 5 liters.
That's exactly
and
right.
our machine cannot handle it.
That's correct.
So we have to lower our pump speed up to like 60.
Correct. That's
So-
exactly right. Yep. And so then we have to, at that point, support the patient, their oxygenation needs. So then we looked for a separate access.
Mhm.
And that's what we got to do. Yeah. Yep. The other thing that we have to think about, just like you heard about with the VADs, there is some fluid balance issues that we have to be careful about. So that's just a conversation, the same conversation that you guys would have with any critically ill patient about, if they're giving a bunch of fluid, giving volume to the patient. We don't necessarily want to take that volume right back off. But those are conversations that you guys are already having. And that's really all that's talking about. This is a little bit like pulled back picture of how this is set up, but you basically see the plumbing there. This is the pump here. There's an oxygenator, a heater that sits right below it. Just a typical oxygen blender and flow meter that supply oxygen to the pump and oxygenator. So. This picture is some of the pressures that we saw, and these are the pressures that I was talking about. This internal pressure, 124. This is our total flow of about 3 liters per minute. At this pressure, it's going to work fine. At those higher flows, though, it potentially is not. Just some references there, and that's really all I had for you. I'm happy to take any questions or talk more about anything.
So when we use the femoral line that on the other side,
Mhm.
we don't have any problem with that, right?
Yeah.
150, no problem.
No, correct. And I don't think that's bad, but I think, especially as these patients, we don't know. Our average run is about 3 weeks that we're on ECMO. Depending on how severe the renal failure is, they may be on CRT for that entire 3-week period. This patient that we're discussing here has been on both CRT and ECMO for going on 4 months now. Do we need that separate Maherker in? He had it in his femoral. It was limiting his ability to have range of motion, to get up. We can potentially have people stand and walk on ECMO. It builds, these are all things that sort of build strength and build core strength and help get them back off the machine itself. So that's all I'm saying with it, I think, is the separate access is fine. But there's a couple of situations where that separate access may not be fine. Those critically ill patients where it's tough to find separate access, and if it's in for a long time, we may not need the separate access. So I think if we can provide it in the circuit and the pressures look okay, I would say why not? Yeah.
How many of these devices do you anticipate purchasing, or just based on what you do?
So we actually started with 3 pumps, which gave us the capability of putting 2 patients on at a single time. It leaves us a backup. We now have 5 pumps, which allows us to put 4 patients on at a time, just because there are not a few times where we've had the need to have 3 patients on. We haven't had the need to have 4 patients on yet, so that seems to be a good level.
When I was at Franciscan, if they needed ECMO, someone would send them to Oregon.
Correct, and Oregon had really promoted that regional support. We also would like to be able to offer that service regionally, and I think in the future we'll grow to that. We haven't taken patients where we've cannulated out in an outside facility and brought them back yet, but we've taken a lot of patients where we've cannulated them as soon as they got to us. Yeah. Anything else? Yeah.
I've only had a limited experience with it, but it was where we were having clotting circuit and we were return the blood, and then said, no, don't do that because of the
air, yeah.
possibility. So it's not black and white, it's basically case basis? Or?
Well, so in the first couple of patients where we tried to access CRT in the negative side of the circuit, returning the blood is not an option. It'll guarantee to entrain air via that.
I wonder why.
It's pulling.
It's aspirating.
It's pulling at 300 mils a minute, 300 millimeters of mercury on the negative side. It's like aspirating with a syringe in that. If any of the drip chambers are close to, you have those drip chambers that are in the CRT machine. If they're even close to allow air to suck down, it just becomes really risky. Typically, as it's plumbed, like I was sort of advocating, like this, the risk of air entrainment is it would be so difficult to happen. I can't even imagine. I would say with this typical situation that we're trying to use now, it's not a problem to return the blood.
It's better to spill blood than to suck air.
Yeah, I think in the first case where we had that negative side, we were accessing it in the negative side of the ECMO circuit. It's just better to throw it out. But now I think with this current plumbing system where we're in the positive side of the circuit, it's not a problem. You can return blood with it.
Yeah. The thing is that if ever you have a problem with the CRT before, you will waste the blood.
Right.
Now we can return it?
Correct.
Okay.
In this system, yes. So this system, in the same way that your physiologic venous pressure is a little bit positive, it's between 3 and 10 millimeters of mercury, your CVP. This system is actually even a little bit higher. If there was to be a problem, something was to come disconnected, blood would squirt out. It wouldn't try to pull air in. When we're talking about it in the negative side of the circuit, it's going to want to pull air in. So even people, if you're giving IV piggyback meds, for instance, that are not on a pump, and they let the piggyback run dry, it'll suck air just immediately in through that. Because your venous system becomes extremely negative in that circumstance. Anything else?
Does our citrate with the CRT affect your anticoagulation efforts?
Yeah, not really. Probably a little bit in the sense that it's not a perfect local anticoagulant for the machine or the CRT machine, but these patients suffer kind of the same thing that you were hearing about with the VADs. These patients suffer a little bit of coagulopathy anyway, so it's really hard to tease out which is causing what. Most all of these patients are going to be anticoagulated on some type of drip anyway, heparin drip or most commonly heparin. So you may not even need to run any additional anticoagulant for your needs. You certainly talk about it because most of these patients are already going to be heparinized. But if you decided to use a citrated circuit, I doubt that it's going to affect too much. Anything else? All right, thank you.
Thank you very much.
And my contact information's on those slides, so
Okay.
certainly reach out if there's any questions.
Thank you.
Okay, thanks.
Yeah.